consultant orthopedic and joint replacement surgeon, specialized in hip and knee replacement surgeries, practicing in Sukruti Orthopedics and Joint Clinic, Jayanagar. Today we are talking on arthritis in young, that's basically hip arthritis in young. The most common reason being the avascular necrosis of the femoral head. In short, we call it as the AVN of the femur. So one of the commonest causes for this AVN of the femur is patients is on long-term steroid intake due to some other reasons in the body, or any anti-epileptics due to some seizures, or smoking, or some many 90% times we don't know the reason, is called idiopathic. In this AVN, what happens is there is going to be disturbed blood circulation to the head of the femur. Then our natural hip joint is a ball and socket joint. So this is actually the socket and this is the ball. The ball has a blood circulation coming from the thigh bone, and this blood circulation unique feature is the blood circulation flows in only one direction. So in this AVN, there is going to be blockage of this so-called the micro vessels, means the small vessels in the femoral head, and eventually that area starts getting necrosed. So as the more and more areas starts getting necrosed, the head of the femur starts getting more and more inward. So here we stage this into 4 stages: stage 1, 2, 3 and 4. Stage 1 and 2 are called the initial stages, and majority of the times in these stages we come across the chronic pain in the hip joint, difficulty in walking, especially what we commonly call it as night cries. Means pain we notice more when you're taking rest at night. This is night cries. So in these times, if you diagnose it stage 1 and 2, so we can treat them in the early stages. We have a lot of advanced options ranging from you do small hole in the femoral head, increase the blood circulation to that area, and then we inject the platelet-rich plasma, or we inject the BMAC, and more advanced nowadays actually what is called the regrow or osgrow, wherein we are going to take the blood of the patients and then we process the potent stem cells and inject into the area. So that will help in the healing of that necrosed area. So if it is diagnosed in the early stages and then treated in the early stages, so 90% of the times actually the disease will come to an alt stage, and so patient will recover. As the stages progress actually, then we call it as stage 3 or stage 4. In this stage 4, what happens is the cartilage on the femoral head, cartilage on the acetabulum continue to destroy, and as the cartilage on both the sides are not there, the bone on bone it starts erosion. When the bone on bone erodes actually, then that causes what is called severe stage of the hip arthritis. And this is the stage wherein patients find difficulty even in standing, sitting on the floor, even in doing his day-to-day activities. And this is the stage actually where he requires so-called total hip replacement. So this total hip replacement, in this what we will do, we are going to remove the damaged head of the femur, and then we are going to remove the damaged cartilage on the cup side. On the cup side we are going to put the acetabulum, that's called acetabulum cup. On the head side we are going to have a stem actually which goes into the thigh bone, femoral, and then we have a head. So this head actually is called ceramic head. So this we put a ceramic and highly cross-linked poly, then we are going to have a better life of the processes. After the post-surgery, patient can be pain-free at least another 30-35 years. So the technology what we use in this hip replacement is called as a minimally invasive muscle sparing approach. In this means we use a small incision of the hip so that we are not cutting any muscles. This is called muscle sparing approach. We are going through the muscle windows, means in between the muscle planes, we enter the hip joint and then remove the damaged ball and then put the acetabulum cup and then the head and then come back. So this is the advantage of this is very minimal pain, early mobilization, very quick recovery, and then normal muscle functions. So this is what is called a minimally invasive muscle sparing approach. With this patient can be ambulated very next day, and usually they need to use walker for about say 2 to 3 weeks, and then after they will be independent enough to do their day-to-day activities.